A comprehensive foot evaluation plays a critical role in the care of individuals with leprosy, as the condition commonly leads to peripheral nerve damage, resulting in sensory loss, muscle weakness, and structural changes in the feet. Early detection through detailed sensory and motor assessments can help prevent serious complications such as neuropathic ulcers, deformities, and injuries from poorly fitting footwear. Routine evaluations are also important for tracking changes over time and guiding appropriate medical and rehabilitative care. Start the evaluation by observing the skin of the ankle and foot. Is the skin dry? Are there cracks or fissures in the skin, especially around the heels and metatarsal heads? Does the patient have callus? If so, is the callus fissured? Is there hemorrhage under or around the callus? Is there redness and/or swelling in the foot or ankle? Compare the anatomical structure of both feet and look for irregularities or differences between the feet. Pay particular attention to any bony prominences. Is there clawing of the toes? Are there any toes missing? Or is there shortening of the toes? In Section 5 of the form, document any foot deformities identified during your examination. Palpation of the nerves can be challenging if the patient has any swelling in the lower legs or ankles. When palpating the nerve, we are looking for tenderness and/or enlargement. The lower extremity nerves involved in leprosy include the common peroneal, the posterior tibial, and the sural nerves. To palpate the common peroneal nerve, find the head of the fibula at the upper lateral side of the lower leg just distal to the knee joint. With your fingertips on the head of the fibula, slide them just posterior and distal to palpate the nerve as it courses around the neck of the fibula. To palpate the posterior tibial nerve, locate the medial malleolus. Slide your fingers just posterior into the groove between the malleolus and the Achilles tendon. Roll your fingers back and forth while you move slowly proximal in an attempt to locate the nerve. The sural nerve is located near the lateral malleolus. Place the tips of your fingers on the lateral malleolus and slide your fingers just posterior into the groove between the malleolus and the Achilles tendon. As you work your fingers back and forth, slide proximally to locate the nerve. Indicate the presence of enlarged or tender nerves in Section 4 of the form, nerve palpation. The sensory evaluation of the foot is conducted with 3 monofilaments that assess sensation levels ranging from normal sensitivity to a complete loss of deep pressure perception. Test all the areas indicated on the diagram to ensure you have a good indication of sensory function in all nerve distributions. It is important for the patient not to watch as you apply the monofilament to the skin, so position the patient appropriately or ask them to close their eyes. Begin with the 1 gram or smallest filament in progress to the heavier filaments as necessary. Unlike the hand, the foot filaments should only be applied once to each location. Apply the filament perpendicular to the skin surface and apply just enough force to bend the filament, then remove it. Application and removal of the filament should take approximately 1.5 seconds. Do not bounce the filament and do not hold the filament against the skin. Test each site 1 time and then move to the next location. You may go back and retest areas where the patient's response was suspect. When the patient gives a positive response, record the score in Section 1 of the evaluation, sensory testing. The lower extremity muscle groups most commonly affected in leprosy are the ankle extensors and the intrinsic muscles of the foot that allow you to separate the toes. To test ankle dorsiflexion, support the heel and Achilles tendon area with 1 hand. Ask the patient to pull their foot up as if taking their foot off a gas pedal. In a normal patient, the ankle dorsiflexors are very strong and require a moderate amount of force to test properly. If the muscle is normal, you will not be able to move the foot downward in a plantar direction. Alternatively, you can ask the patient to walk on the heels of their feet. The patient should be able to do this without much difficulty. Weakness or paralysis of this muscle group causes foot drop. To test the function and strength of the intrinsic foot muscles, ask the patient to spread their toes. Inability to perform this movement can indicate weakness in the intrinsic foot muscles, and over time can contribute to development of claw-toe deformity. In Section 3 of the form, muscle testing, mark strong, weak, or paralyzed for the corresponding muscle groups. Once you have completed sections 1 through 4 of the evaluation, determine the patient's WHO grade and risk category. If the patient was able to feel the 1 gram or 10 gram filament at all sites, they are considered to have protective sensation and given a WHO grade and risk category 0. If the patient does not feel the 10 gram monofilament at even one site but has no HD-related deformities, they are given a WHO grade and risk category of 1. If the patient is unable to feel the 10 gram filament and also has an HD-related deformity, they are given a WHO grade and risk category of 2. If the patient has ever had a history of a foot ulcer or Charcot deformity, they are placed in risk category 3. Once the patient's risk category is established, indicate whether the patient's footwear is appropriate for their risk category. Patients in risk category 1 will need regular monitoring and may need protective footwear depending on your evaluation. Patients in risk category 2 or 3 should be issued protective footwear, including extra depth shoes and custom insoles with targeted relief of high-pressure areas if necessary. If you would like more information on performing a foot screen or have questions regarding Hansen's disease, contact the National Hansen's Disease Program at 1-800-642-2477 or visit our website at www.hrsa.gov/Hansen's-disease.